From the Zoomerplex in historic Liberty Village, the Zoomer, hosted by Marissa Lennox.
Welcome to the Zoomer. I'm Marissa Lennox. Healthcare is our focus today. It is a big part of Canada, something we all care about. But it's not working like it should. And the pressing question is how to fix it. To inform our discussion, we asked you to share your experiences with the healthcare system. And let me tell you, the response was overwhelming. So in our commitment to addressing what matters most to you, we are tackling this head on today, and we'll share some of your stories throughout the show. But first, we begin with Vancouver orthopedic surgeon Dr. Brian Day, who in 2009 took on the BC provincial government, launching a 14-year battle to challenge limitations on private care. He joins me now. It's great to have you on the program.
Thank you for having me.
Now, you fought to allow patients access to private care when the public system could not deliver timely care. Ultimately, it made its way to the Supreme Court and it was dismissed, but it took 14 years of your life, which suggests a deep conviction. Tell me what it is that drove that conviction.
Well, for example, when I came to Canada quite a few decades ago now, there were no wait lists. Access was fine, but things have changed, and every Canadian knows that. As soon as you need healthcare, you will realize that it's not the promise is not being kept. And when I came, for example, Canada was between second and fourth in the world in doctors per capita, and today, according to Index Monday, we're 69th in the world. And this was from a strategy of rationing. You know, you talked about the courts. We actually only went as far as the BC Appeal Court because the Supreme Court of Canada refused to hear the case, which was strange considering they'd already heard that case, a similar case in Quebec in 2005. But anyway, they didn't give reasons. But the BC Appeal Court made some very remarkable statements. One of them was, for example, wait time. This is a direct quote. Wait times, in considerable measure, flow from deliberate government rationing of healthcare, and the system is intentionally under-designed in order to achieve fiscal sustainability, and that waiting, and this is again is a direct quote, inherently carries the risk of death. And as you know, the Second Street group have come up with a government, based on government data, that 35,000 Canadians a year die on public wait lists. And the point being that it's illegal for them to do anything about it as long as they stay in their own province.
Well, I wanted to ask you about that. The deaths that have been reported by secondstreet.org, but also the 3.1 million Canadians that are on wait lists for surgeries or scans or to see a specialist. Give me an impression of what the problem is. What is at the root of that?
Well, the root of it is a very inefficient health system. You know, Canada is, we have 14 ministries of health for a population of maybe 40 million. And a country like Germany, for example, has one minister of health and one ministry of health. And a lot of Canada's, and yet we're spending very high, massive dollars on our health system. We're one of the most expensive, apart from the United States, on a per capita basis. We're up there near the top. And yet, it's by coincidence, I actually was speaking to a German orthopedic surgeon just a few days ago. And I just kind of off the cuff said, in the public system in Germany, when you need a hip or knee replacement, how long is the wait? And he replied, oh, it's quite a long wait. It might be as long as 5 or 6 weeks in the public system.
Right. And what is it here?
It's a couple of years here. So, and the interesting thing is 10% of the German population has private insurance. And my point is that having that competition for the public system keeps the public system having to compete and keeps it honest. And, it gets back to the basic principle. I don't think there is any monopoly And Canada is the only country in the world that has a state monopoly on healthcare funding and delivery.
Can you clarify something for me? Because I know you're the owner and you're the medical director of Cambie Surgery Centre in Vancouver, which is a private medical facility. So how do you continue to operate in light of the Supreme Court dismissal? Can you make sense of that for me?
Yes, I am the medical director, but I'm only one of 50 shareholders. So the interesting paradox is that well, first of all, there are exempted groups. So the exempted groups include workers' compensation patients. So if you're injured on the job, the Workers' Compensation Board pays for you to go to a private clinic because they don't want you to wait 2 years, and they're paying you, sometimes thousands of dollars a month while you wait. So, but there are other surprising exempted groups. For instance, the judges that sit and hear the case as to whether private insurance should be allowed for all Canadians. They're allowed to have private healthcare. They're exempt. Prisoners and federal police officers are exempt. And I kind of cynically, ask the question, our case or state the point that our case was really about trying to get the same privileges and rights for Canadians who are not in jail as those who have as the rights that those who are in jail have. I mean, this is a ludicrous system. And the other group is if you move from one province to another for your healthcare, you are also exempt. So we have the strange situation now where British Columbians are going to Alberta because out of desperation, and Albertans are coming to British Columbia, and that's quite legal. So people who are from a different province have rights in your province that you don't have.
Wow, that is bizarre, to say the least.
Well, the other thing I should say, there is only one country on the planet, and that includes all of the communist and authoritarian countries. There is only one country on the planet where private health insurance is unlawful, and that's Canada.
There are provinces, Ontario, Alberta, even BC, distinguishing from private financing to private delivery. Are you encouraged by what these provinces are doing as far as private clinic collaboration?
Well, I think it's necessary, but we should have the right to a right that exists in every other country on the planet, including communist countries like China and Vietnam and Laos and Cuba. These countries do not make it unlawful to care for your own health, which is what we have a government that promises healthcare, fails to deliver it in a timely manner, and then makes it unlawful for you to do anything about it. And then the other thing is that, and this is a massive thing, we're the only developed country that exclusively funds our hospitals with a fixed annual budget, which means that every patient that goes to a hospital is consuming the hospital's annual budget. In every other country, so in Britain, for example, or in the Scandinavian countries, in New Zealand and Australia, if a patient in the public system goes to a public hospital, the government pays the hospital for that procedure. So here there is an incentive for on the part of the hospitals not to treat patients because they use up their annual budget. I mean, it's bizarre. It's a bizarre form of funding.
Now, I know you're a believer in the public system because I've heard you say it before. And of course, there have been studies and debates looking at privatization in healthcare. I'm sure you saw one out this week, a review from Oxford, looking at the effects of taking public hospitals and making them private. But my question to you is really, what do you say to critics that say you can't be a for-profit service provider without putting profit first?
Well, actually, what you do is you put patients first because you need patients to survive. And we have the data on private hospitals and public hospitals and their costs. and we have that data from auditors general. We have it from ministries. So we don't need to look at studies. We need to look at the government data, and governments know that it's actually more economic for them to contract out surgeries. It's more efficient. It all comes back to where I said earlier, that there is no monopoly that performs well or performs efficiently. There just isn't.
It's a good place to wrap our discussion. Dr. Day, I appreciate you taking the time.
You're welcome.
Our medical panel is standing by on the other side. Stay with us. We're back, and I'm joined by our medical panel now, eager to weigh in on the conversation with Dr. Brian Day. And Dr. Gorfinkel, I'll begin with you, because in many countries worldwide, patients have the option to choose between public care and private care. Would Canada be wise to follow suit?
Complicated question, but let's just say this. If there's no oversight, Canada will have a serious problem. Patients are vulnerable, especially when they're unwell. So if I'm unwell and I'm seeing somebody who doesn't have oversight, what are the possibilities of things that can happen? I can be upsold on services that I may not need. I may be referred within that same community of providers to have services that I'm overcharged for. And because I'm vulnerable, I will not necessarily recognize that, and I'll feel compelled to pay it.
What do you mean by oversight?
I'm talking about strict government oversight and watching what goes on. Let's talk about what happened with the nurses. In Newfoundland, they were charging, this is Canadian Health Labs, they were charging $300 an hour
Which
for
is a
nurse.
private nursing agency, just for...
Private nursing agency, thank you. They were charging $300, paying them $100, and pocketing $200 of taxpayers' money per hour, per nurse, and that represented 5% of their nurses during the pandemic. So desperate governments do desperate things.
Bill, I'll ask you the same question.
In terms of privatizing healthcare? Yep. Absolutely, within reason. As Dr. Gorfinkel says, what we're looking for is results. Patients, seniors, Canadians want results from their system, and they're not seeing results. And that's the number one issue. And if that can be provided, as it appears it certainly could, one of the things that we often are kind of amazed at is people are always saying that government doesn't deliver services very well. Yet in one area, in healthcare, so many Canadians seem to think that somehow government can do a better job than private industry can. And that just doesn't make sense.
Dr. Cherniak, I'll go to you next, because nowhere are wait times more pronounced than in hospitals and in the emergency departments. Are you encouraged by what Ontario is doing as far as private clinic collaboration? Are you seeing an impact on the front lines there?
This is a really complicated question. I don't know that I've seen an impact from sort of private clinics on the emergency department per se. I think my lens is a little unique because I've practiced clinically both in Baltimore as well as Alberta, Ontario, and overseas in East Africa. And I sort of take a systems approach to healthcare and look at how different each individual place is. I think we have a really interesting opportunity in Canada because we have a publicly funded, privately administered healthcare system with a single government-funded payer, which is, in the province here, OHIP. And so there's a really interesting opportunity to build an integrated system that provides access to care for everyone. The challenge becomes when that system isn't fully funded, or there are areas that sort of slip through the cracks. And so I think people should have a choice if the system isn't providing appropriate coverage for something that they need. But ideally, we can try to strengthen the public system, is my perspective.
One of the critiques of this has been that the private system charges more for procedures than the public system. Does it matter if the job gets done faster?
It does matter because every resources are finite. So the system we have now is based on your needs, not on your ability to pay. That's what Tommy Douglas brought us. He brought us Medicare, where when we go to the hospital, when we go see a physician, they give us what we need, not what we're able to pay for. This is worth preserving.
But there's another aspect to this. Where are the healthcare workers going to come from? The healthcare workers that man that clinic have to come from the public system. There's simply no other way. All the healthcare workers come from the public healthcare system. So if they are to be co-opted into going into the private system because the money is just so much better, where does that leave the public system? Answer, with fewer healthcare providers. And that's a serious problem.
All right, we need to take a quick break. We'll be right back. And up next, we've got emails from viewers sharing their healthcare experiences. Stay tuned for those stories and our panel's reactions. Welcome back. As I mentioned earlier, we've been getting emails from viewers sharing their healthcare experiences. We can't read them all, of course, but we've selected ones that hit on common themes, giving us a broader view of our healthcare system. This one is from Jackie. Here's what she writes. I was diagnosed with cataracts in December of 22, subsequently put on a wait list for OHIP-covered surgery. However, the wait list was in excess of 2 years, and my eyes were getting worse. By February of 2023, I had to give up driving, so I had my optometrist reach out to a private clinic. At the time, Doug Ford publicly announced Ontarians wouldn't have to pay out of pocket at private clinics. OHIP would pick up the tab. Not so. I am out of pocket $7,900. Jackie then describes in her email that she reached out to her provincial rep, she reached out to the health minister, she reached out to the premier, and she has received absolutely no response. And she asks this: it would be interesting to find out how many Ontarians like me are thousands of dollars out of pocket and have spent months in a one-way communication campaign to try to get their money back. MPP Gélinas, have you heard stories similar to this?
I have heard so many stories. So I was invited by a seniors group to come and talk about home care and how to gain access and stay home. At the end of my talk, I said, I know a few people have talked to me about being billed when they had cataract surgery. If you want to talk to me, come, I will be over there. Over 100 people got in line to talk to me. They had all been billed extra for their cataract surgery. And some of the amounts are the same as what you've seen there, thousands of dollars extra. So there's a place where you can put in a complaint in Ontario. Nobody knows that. And even if you do know it, it's not easy. So you phone there, 2-3 weeks later, you get a call back. They ask you a bunch of questions. And if you qualify, they will give you your money back for the person who does the complaint. But for everybody else who was billed the same amount by the same ophthalmologist, nothing happens. So there is zero oversight. It happens every day to hundreds of people that gets overcharged for cataract surgery, similar to the story you've just said. The government knows this. I have brought it to the Minister of Health hundreds of times, and they do nothing.
Can you make sense of this for me? Is it a matter of being overcharged? It sounds like she was charged the full amount.
So if I'm a desperate patient, what choice do I have? The choice for this poor patient was really to wait the 2 years, to lose her driver's license, or to pay the fee. Mm-hmm. So this is a systems problem, right? It's not a problem with the necessarily private per se. It's a systems problem. The lack of oversight, the lack of transparency on the part of clinics. They're not forced to say how much their fees are up front. It might be more of a question of, once you're in the chair, how much can they get? And I hate to say that because it sounds so predatory. Mm-hmm. But then on the other hand, we have to face what it is that private medicine provides. Private medicine must look after itself first, and not necessarily the patient, in order to make a business run. That's just the reality of it.
What have you heard from CARP members about this program?
Well, we do hear that kind of story, and it's very true. And the problem, as both the other panelists have said, it's oversight. Here's a government that's supposedly looking after us and looking after our health, allowing this kind of thing to happen. If you've had cataract surgery, as I have, you know there are different choices that you can have between the different levels of lenses that you get, and you need to be educated so you can make those choices. Why isn't that built into the system by the government, saying that these clinics have to disclose what the options are, and then people make their own choice, which is what they should be able to do in the long run.
And what's covered and what isn't covered.
What's covered and what isn't, yes.
I would add to this a centralized wait list. There are some ophthalmologists that don't have big wait lists. Why don't we have a centralized wait list so that right now, most of the time, your family physician or optometrist refers you to the ophthalmologist that he knows, and that's fine. But if we were to, like in British Columbia and Alberta, they published a wait list by surgeon on a website that everybody can see. So you can go and look and say, okay, well, this may be another 15 minutes drive, but he has a 6 weeks wait list, or I could be on a 2-year wait list for the one who is closest to my house. Maybe I will drive the extra 15 minutes.
There's something really interesting about the single payer system that we have in Ontario and everything being integrated, and that potential opportunity with the single referral system. So, at the height of the pandemic, at the first wave when folks were really sick with COVID, the emergency department ICU beds and otherwise critical care beds were full, but we have a provincial system where you can transport patients called Orange to various facilities. And so if a hospital ICU was full, you could then take one of those patients, fly them from downtown Toronto to Northern Ontario where there was an open critical care bed. And that was and we saw that, I saw it personally in clinical work where a bed was opened up and a patient immediately filled it the next day. So I think there's a really interesting opportunity with a centralized referral system where you might have a doctor who has availability, and then if a family doctor who's really busy or an emergency doctor who's really busy can see that, you can make the right choice of telling the patient where to go, or even a patient-directed system where they could look it up themselves, I think is really interesting.
All right, we need to take a quick break. We've got a lot more ground to cover. Stay with us. We're back. Still with me is our medical panel, and as I mentioned earlier, your experiences are shaping our discussion today. Up next, Zoomer Radio's own Sam Houston. She writes this: the struggle to find a family doctor in Ontario has had a heartbreaking impact on our family directly. My amazing brother-in-law, Jeff, is a retired fire captain in Ottawa, fit and strong and a hero to us. He dedicated his career to saving other people's lives. 2 years ago, Jeff started to show symptoms similar to Parkinson's disease. It was around the start of his symptoms that his family doctor decided to close his practice. And Jeff, my sister, and all the family have been trying to get him a family doctor ever since. Imagine a life-changing condition and no steady, committed family doctor to guide you through, hold your hand, make referrals, and get to the bottom of these symptoms. Instead, it has been my sister who has navigated the healthcare system on her own, finding specialists, getting Jeff in the queue. How can a hero or anyone dedicate their entire life to helping others and then not find help when he really needs it? As I share this story, Jeff is still searching for a family doctor as a family medical practitioner. How do you react to such stories?
It's heartbreaking. It gives me the very same feeling that I get when patients are calling my office saying, well, can you take me as a patient?
And what do you say to them?
We're full. And I say that, and then it's invariably followed up with the next obvious question, where am I to go? Silence. Like it genuinely is silence. And then we'll say something like, well, you could call the College of Physicians and Surgeons. And my heart is sinking because I know what it means. The likelihood of them finding a family doctor is pretty low, and it feels terrible.
So what are we to do? There are 6 million Canadians without a family doctor.
There's 2.2 million Ontarians right here, right now, that do not have access to primary care. In Northern Ontario, where I'm from, Sault Ste. Marie is about to let go of 10,000 people that are registered with a group health center that will find themselves without access to primary care without a family physician. But yet, where I live in Northern Ontario, where 40,000 of the 89,000 people I represent do not have access to primary care, I have nurse practitioners who would be more than happy to join a family practice and offer access to primary care to people. There's a nurse practitioner in Sudbury who would go help in Sault Ste. Marie right now what they're living through, and yet we have a government who refuses to fund them. Give them a team of people who can help them. You've lost your spouse, maybe talking to a social worker or a psychologist would help. You've been diagnosed with diabetes, maybe talking to a dietitian. Give them the opportunity to work within a team, because there are unemployed nurse practitioners, there are unemployed social workers who would love to work in a primary healthcare team so that we can onboard many of those people. They've made requests for funding to the government, and the government ignores them.
Well, the government has expanded their role, their scope, however. What impact has that had? It's not just Ontario, many provinces have taken steps in that direction.
Yeah, I think expanded scope of practice is an interesting also opportunity to let people practice within their training in order to expand capacity in the system, and where they have appropriate oversight, where they can also ask for help and support. So I think that's an interesting opportunity, and certainly in the emergency department, I'll work with physician assistants or nurse practitioners, access to funding for reimbursement for those services, and making sure there's appropriate oversight. It's part of the challenge. But one of the things I was thinking is that technology is a great opportunity, and so one of the reasons I started Rocket Doctor, a digital health company, is because I was seeing all of these patients coming to the emergency department with outpatient primary care issues who couldn't access family medicine. And so I was thinking, we have this resource allocation issue. We have all these, doctors in urban academic centers and big cities. Couldn't we get them out to patients in rural, remote communities by leveraging a cloud-based technology platform where you could then connect a patient to a provider and then allow them to, follow up with each other and book blood work and, other tests. And so what we saw, though, is it was working great during the pandemic, but then in Ontario, we've actually had funding for virtual care scaled back in December 2022.
So I wanted to ask you about that, because you're right. I was really encouraged by access to virtual care, and it kind of ballooned during the pandemic, and it seems like BC and Alberta have really embraced it. Why did Ontario scale back?
I don't know. I think, I guess there's a lot of sort of complexity around that in terms of how various sort of reimbursement models work in the province and otherwise. But the impact that we've seen, like we just published a study in November where we surveyed thousands of patients on the platform before the funding cuts. And what we saw was that, interestingly, 50% of patients were from rural, remote communities, and 36% of patients actually said they were using physicians on the platform as their family doctor entirely virtually. And so, there's a great opportunity here where we can leverage all of these supports. We just have to make sure that the health insurance funds it appropriately, so then clinicians will do it, and then it'll be available for patients.
I'll give you the final word, Bill, because I know this is core to CARP's advocacy.
It absolutely is, and there's no question that the lack of care for patients is the major issue, and family doctors have been the core of what's been delivered, but we have to expand on that now. The use of nurse practitioners, as we've talked about, backed up by remote help from specialists. There are examples across the country in provinces that are experimenting with that, working with movable health clinics with doctors and nurses who go from community to community to give those family practice. The problem is not the where we started in terms of should it be private or should it be government. What's the best way to offer the service, even by government? And it's going to be a mixture. Let's embrace that and then make sure we get the best care for everyone through it.
All right, let's take a pause here. Coming up, the increasing demand for home care and why a recent McMaster University report says we need nearly 7,000 more PSWs to keep up. Next. Welcome back. Across Canada, the demand for healthcare workers is growing as an aging population increasingly relies on home care. According to a recent report from McMaster University, Ontario alone needs about 6,800 extra PSWs by 2028 just to maintain current levels of service. In the meantime, home care is facing challenges from chronic underfunding to shortages of underpaid workers, and it resonates with stories like Margaret's. She puts it like this: "My husband and I are in our 80s. He has Alzheimer's disease, and I'm not able to give him the help he needs. Initially, after an assessment, he was given 1 short visit per week, which later increased to 2. However, coordinating showers became difficult, and he often missed them. After a fall and a shoulder injury, they sent someone in the morning and at night, but the timing and unfamiliar faces caused issues. We had to hire private home care, but it's still insufficient. I can't imagine how others without a supportive spouse or endless savings manage." This is such a big issue, Bill, for CARP and for CARP members. Just describe the impact, the measurable impact on financial and quality of life aging in place has.
Yeah, certainly does. And, everyone wants to stay in their home. We want to keep our loved ones in our own homes, but being able to do it is becoming less and less realistic, and supports have to be there for caregivers. We need to support the family caregivers, all the millions of dollars worth of time that's being contributed by family caregivers. We need to support them, and we need to have some kind of government support for the costs of family-funded home care. One of the things CARP has been advocating for is having taxes reduced or eliminated on all the costs of home care. If in many provinces, if you're getting home care through an agency that's being hired by the province to deliver the home care, there's no tax paid on that. But if you individually hire the same agency, you're taxed on it. That would be a way of immediately reducing part of the cost of family-funded home care.
MPP Gélinas, I remember going to a meeting with someone in government, I won't name who, but I remember talking about this specific issue, and they said to me, "We have no money. There's no money." And I guess, the government can't pay for everything, but this seems like an obvious one. There would be financial savings to invest here.
You're absolutely right. Our home care system in Ontario is broken. It fails more people than it helps every single day. Why? You remember Mike Harris, who decided to privatize home care? The Bayshore of this world and the American companies were going to do things better, faster, cheaper. They did not. Right now, Bayshore makes hundreds of millions of dollars in profit every 3 months on the back of people who don't get the home care that they need. We have the money. We know how to do this. My hospital puts out 1 job for a PSW, they get 500 people apply. But none of the for-profit home care company are able to recruit and retain a stable workforce, which gives you quality care. You don't have quality without continuity of care. Why? Because they're not good job. Make PSW job good job. Give them a decent pay. Give them benefit, a pension plan. Pay them for travel between clients. Make sure that they have a few sick days. And there is a lot of mainly women, very good women who are really good at doing PSW work, who love to do home care. But if they work in home care, they can't pay their rent and feed their kids.
I bet if we were to survey the room, 100% of people in this room would say they don't want to end up in long-term care. They'd rather age at home. It's tough work. Do you know what the earning bracket is for PSWs?
The going rate now for a PSW across Canada is between $20 and $25. So remember the private nursing agency I was talking about? They charge the government $100, 4 times that amount. So they were actually paid between $25 and $50 an hour. So it is very expensive when governments make a mistake. When governments aren't aware of what's going on and aren't paying fairly for work that deserves to be paid. They're simply not paying what it needs. And let's take a look at that patient, right? That poor fellow, he falls, who knows, he fractures his shoulders. Talk about costs. Here's how it often comes out. He goes to the hospital. The wife says, "I'm done. I cannot manage this." Where does he go? Where does it go, Dr.
They say,
Cherniak?
will you please admit us to hospital? And I say, we can't admit you to hospital because the service won't take you and there's no beds.
I'm not
And so
leaving,
then-
Dr. Cherniak.
Yeah.
I'm not leaving. I can't
Yeah.
manage this.
Yeah,
Then
I
what
see
do
it
you
all the
say?
time.
And then-
we can get you CCAC. We can try to make a
No,
requisition
I'm
for
not
home
leaving.
care.
I can't
Yeah.
manage this. So where does the patient wind up?
Well,
you know where he winds up. He winds up in an acute care bed, chronically admitted.
Yeah, you call
That's what
medicine
happens.
fast to help and admit the patient and deal with, yeah.
So that's a serious problem. And for me as a family doctor, it's heartbreaking because people cannot afford 24/7 care. Yes, they want to stay home. Yes, they have the support socially, but physically, it's extremely difficult.
All right, we need to take a quick break. Then we're back with more real stories of our healthcare system. Stay tuned. Welcome back. We're opening the floor to our live audience for their questions now, starting with Shuva.
Well, thanks for having me. I just had a hip replacement in December. This is my 4th joint replacement. I had both my knees and my left hip and my right hip in December in Sunnybrook Hospital in Toronto. But I got infected again, and they had to open me up again, second time. Now, that's all fine. I have no complaints, but my thing is I never got 1 day of rehab anywhere, no help, nothing, after 2 major surgeries and after I got infected. So I was just trained in the hospital for physiotherapy the first time for 15 minutes. And after the second surgery, that was only like yesterday I had the session, that was for an hour. And those were very hard physios. I don't know how I'll be able to manage at home, but I was told that that's the only thing government funded. I cannot go anywhere outside unless I pay on my own. So I was just wondering if there are any other facilities by government that I can get help from with physiotherapy.
I listen to that, and I'm filled with so many emotions. I'm filled with rage, and I'm filled with shame. Shame for a system that isn't looking after you as they well should. So we know that physiotherapy is probably the most important part. You know the old joke among surgeons? The surgery was a success, but the patient died. And it's a black joke. It's a very nasty joke. But there's actually truth to that. I mean, I see the tears in your eyes, and my heart goes out to you for a system that is really on its knees. And the answer to that has to do with family doctors like me being able to connect you to a team member who can then help you. A physiotherapist who would come to your home, make sure that what you're doing is right, and not necessarily babysit you, but say, I'm going to be back in a week. This is your exercise. Let's see how you're doing it.
Because I'll share with you. Hours help at home, at least to show me if I'm doing it right.
Absolutely. Without that muscle built around that joint replacement will fail. That's the bottom line. You need the muscles to absorb the shock so that less force is going through that joint, and all the muscles have to reorganize. And how is that going to happen unless you have a team that is looking after you? I see it all the time with orthopedics, and orthopedics especially. They underestimate and devalue physiotherapy. Good for you for speaking up. I see how hard this is for you, and my heart goes out to you. But I can only hope that it's conversations like this that will actually change systems.
Thank you.
Shuva, thank you for your candor. Welcome to the roundtable. What's your name?
Hi, I'm Larissa.
Nice to meet you. And your question?
My question, I think everybody here can relate to this situation. What do I do if I need emergency care and I don't want to go to those overcrowded ER rooms, or I might have to wait 12 hours or more, where I'm going to be exposed to God knows what? What do I do?
Yeah, this is a problem I'm dealing with every day with patients. And you know what? They are short of breath, they got chest pain. For the life of me, it sounds like they could be having a heart attack or a stroke. And what do I say? Please go. Take your health seriously. It's an opportunity that we cannot miss. For a lot of these problems, the clock starts ticking. But then, I think Dr. Cherniak can take it from here and describe what the situation is like when he sees that patient and what he faces in trying to get them admitted to a hospital bed?
Yeah, I mean, the Canadian Association of Emergency Physicians is advocating strongly that part of the challenge we're seeing in backlog in emergency departments is when folks end up getting admitted or need an admission, but then there aren't hospital beds or acute care beds. And so then it backs up into the emergency department because our beds are full trying to take care of folks. And then it backs up into triage and the waiting room. And so, of course, it starts with primary care, it leads into acute care beds, it backs up into the ER. And so it's a whole system that's been interconnected in this way, basically.
So the problem is one of having enough acute care beds. So where are the acute care beds?
Well, I can tell you that in Ontario, 1 in 4 bed is occupied by somebody who should not be in the hospital, who should be receiving home care, who should be in a supported living environment, but they have nowhere else to go, so they are in an acute care bed, often for months at a time. The average in Ontario for somebody to occupy a bed waiting for care elsewhere, rehab or whatever, is over 3 months per patient, and we're talking 1 bed out of 4.
I had no idea it was that bad. Over 1 in 4 acute care beds is taken by a chronic care patient. Do you have any idea the cost difference between a chronic care bed versus an acute care bed? Do we have some numbers here?
In general, it's $750 per day to live in a hospital. It's about $180 per day in a long-term care home. It is, if you, in a group living situations with level of care to long-term care, it's about $98 per day.
And I think back to the audience member with the first question about the physiotherapy and hip surgery, and I was just rolling in my head what happens next, which is you don't get physiotherapy, which is a cost-effective, helpful outpatient solution that makes you feel better and stay at home and be healthy. So then your muscles get tight, you maybe have a slip or a fall, you get an infection, you come to the emergency department, you see me, I try to do what I can for the acute care issue. Then we talk to the orthopedics, they don't want to admit you because there's not enough beds and it's not an acute care issue. And you end up on the medicine floor, then we don't know what to do. And so it's a whole spiraling system that actually ultimately begins with how do you manage outpatient primary care issues and how do you build that system much stronger to then support the acute care system so that when you're sick in the middle of the night, you have a place to go and you don't have to wait for 10 hours.
Yeah.
That's part of it's all connected.
Agree.
All right, Larissa, thank you for your question.
Thank you.
And that is it for us this evening. To get in touch, you can send us an email at comments@thezoomer.com. As always, thank you to my panel for this very, very important conversation and for you at home watching. We'll see you soon. For now, it's time to zoom out.